The number of people with diabetes has reached alarming heights, and the continued rise is partly caused by the way we eat, move, sleep and live. The impacts of diabetes can be felt in the health and lives of the many individuals affected, as well as the economic costs for individuals and societies faced with this demanding challenge. Diabetes is an important cause of premature death and disability, and is such a serious threat to individuals and to societies. According to the 2016 WHO report on diabetes, the incidence and impacts of diabetes and other non-communicable diseases can largely be prevented or reduced with an approach that incorporates evidence-based, affordable, cost-effective, population-wide and multi-sector interventions. Let us ask the scientists which kind of interventions they would prioritise as the most efficient interventions to fight the global diabetes epidemic if they were in charge of the global priorities. Let us begin with Professor Steve Bloom.
So if I were a Minister of Health, I would advise people to eat less food. I might even put a fat tax on food to make high-calorie food expensive. I might even stop people advertising high-calorie food. I would perhaps remove sweet shops from near schools. But eventually, when there's delicious, highly advertised food available all the time, I can have a Snicker bar in my pocket and eat it on the way home, we're going to be at risk of becoming fat. And for those of us at the greatest risk, then we're going to develop diabetes. So we've got to find some other way of bringing appetite down to match our now plentiful food supply so that people aren't tempted to overeat all the time because they have a more limited appetite. And that is basically what our research is about, how to control your appetite to match today's environment.
Controlling our appetite, creating policies and environments that support people to maintain healthy body weight, healthy diet and physical activity is also at the heart of Associate Professor Signe Torekov's research.
By really having a profound lifestyle change, you can prevent diabetes. But the problem is that it's very difficult to maintain this lifestyle change. So legislation should be more towards that the easy choice is always also the healthy choice. So healthy food should be much more cheap, and in the same way, it's not. There are many places where it's difficult to do active commuting to work, so that should be made much more easy. So the whole combination of exercise, healthy dieting, using pharmaceuticals to help you reducing appetite. I think that should solve some of the problems.
Make the healthy choice the easy and cheap choice. Urban planning and transport systems that encourage physical activity, as well as lowering the price of healthier foods, are also policies that will promote and support needed lifestyle changes. Even though some people with diabetes can manage with lifestyle changes and without use of medicine, for others, medicine is vital. But diabetes medication is very costly, so besides it being knocked out by the disease, it also seriously impacts the finances of individuals and their families. The ultimate price, though, is paid for by those who depend on life-saving insulin without having access to it.
As we already touched upon, some of these modern medicines for type 2 diabetes, they're very expensive. And there's not a chance in the world that poor nations can afford that at all. And that means that they will have an inferior therapy, if any, of type 2 diabetes. And that, of course, will create a big and serious inequality. And they are then left with a greater complication rate and a greater mortality because of the improper, inadequate therapy that they're able to offer because it's too expensive. And how you solve that problem is really an interesting question. And I cannot answer it for you because it is a political issue, obviously.
Besides of lower prices ensuring access for vital medicine, there might also be a way to prevent people at all from the need for medicine through a different understanding of the disease itself. Pricing of medicine is a political question, yes, and as well as is prevention and treatment strategies. Let us listen to how Professor Arne Astrup would prioritise if he were to decide on what intervention would be of great importance to address the global diabetes challenge.
Well, I think it's quite sad really to see that the entire stage is for the pharmaceutical industry, because it means that you need to be medicalized, and you have a disease you need. It's for an individual, you suddenly become a patient, and it's a chronic patient and you'll never get out of it. So it's both for the individual, the patient who suffer from it, that the patients are not offered the treatment that could actually make them much more happy and more healthy without all medications and all these treatments with side effects, whatever. All the funding and all the resources need to be reallocated into prevention and screening, etc. I think I would make it much more evidence-based recommendations also to prevent type 2 diabetes, and reach out to governments around the world that really to make some activities really to convince them that they should change their policy, and they can remove a lot of the resources they spend on treatments that could be removed into prevention and early prevention of type 2 diabetes.
Moving health systems into a new direction, as Arne Astrup explains, seems to be a wish for the shift from seeing the disease as a fixed life sentence to see diabetes as, in many cases, a curable disease. Now let us shift our focus to the ongoing research and look at low and middle income countries.
Okay, I think the first priority, in my opinion, is we need to address the data gaps. When you look at the global burden of diabetes, we are doing all of our research, or in fact most of our research, in populations which contribute to about 5 or 10% of the cases of diabetes. And we have pretty much ignored 90% of the burden of diabetes that is occurring in low and middle income countries. To reiterate that point, over 90% of the global burden of diabetes is in low and middle income countries, but 95 to 98% of research is in high income populations. This mismatch is a serious worry because not that the populations are genetically different, but you're talking about populations that have been separated by 100 or 200 years of industrialization, and therefore bring very different phenotypical susceptibilities. So my number one priority would be to strengthen surveillance and epidemiological studies and basic science studies in low and middle income countries, so that we don't naively assume that findings from high income populations would automatically apply to low and middle income countries.
We know many effective ways of managing diabetes on the patient level, but what we need is more knowledge about reducing risk factors and managing the disease in low and middle income regions. It really is a complex disease. Let us listen to the last scientist for now. How would Professor Juleen Zierath go about solving diabetes globally?
All right, that's a big question. And the reason why it's a big question is because we live in a very diverse world. Okay, so I think the challenges that we're faced in perhaps Europe and North America and Australia are very different than the challenges we face in Africa, in India, in other regions of the world. And I'll give you an example. I was just in Uganda, and I think that there is becoming a tsunami of diabetes. And they're at a stage where they've been surviving HIV and they've been surviving infectious diseases. And because these people are able to survive those viral infections, they can live longer, and they're getting diabetes and obesity. they don't have the infrastructure set up. They don't have the ability to do the diagnostics, and they also have cultural barriers because most of the indices for diabetes treatments are for Caucasians. We're getting more and more for Africans and Asians, but we haven't gotten enough information to be able to understand the diversity in our world and how different groups of individuals are behaving when it comes to diabetes, how they're responding to diabetes. So I would say the first thing we really need is we need to have healthcare professionals who are really trained to be able to diagnose and recognize diabetes. We need to have individuals who can really work with people to help them understand the lifestyle risk that can accelerate their course to diabetes. And we need to have better treatments that are tailored to the diverse populations that we need to serve. So I think it's huge, actually, and I don't think that it's going to be one fix for all regions of the world. I think in the US and maybe Europe, we're in a very different situation. Many people understand their risk, they're able to get treatment, and they're able to make informed decisions about their lives. But I think, again, if I mentioned Africa, you go there, the challenges that the citizens there are facing are huge, and it is daunting. So I would really, like I said, healthcare professionals, educators, nurse practitioners, and individuals that can help with the prevention of the disease and increase awareness. I would start with that, and even the Western world would benefit from more as well.
Fighting the global diabetes epidemic might look like a complex affair, involving many different actors at a time: governments, healthcare providers, patients, civil society, food industry, and suppliers of medicines and technology. But the future will hopefully show efficient solutions leading to a decrease in the number of people getting diabetes and maybe even a cure for those already having it. Thank you for joining our course. I hope that you have learned something new and that you will join the global conversation about how best to deal with diabetes in our communities and societies around the world.